The broadcast is now starting. All attendees are in listen-only mode.
Sound what? Hello everyone, welcome to the webinar, Cancer Data and Policy Issues for Asian Americans, Native Hawaiians, and Pacific Islanders. This webinar is being hosted by the Asian and Pacific Islander American Health Forum and the Asian and Pacific Islander National Cancer Survivors Network. My name is Roxana Bautista, and I am the Network Development Director here at the Health Forum. I'm joined here with Trish Klema of our engagement team. The Health Forum is a national Asian American Native Hawaiian Pacific Islander policy organization. We are... I can't hear you guys. It's not on yet. Oh. Wait. Oh. It's not on yet, you guys. Hold on. No one can hear. Okay, so... Hello, everyone. Did you hear my introduction? This is Roxana. Cool.
I heard it. Yeah.
Okay, just wanted to check. Okay, so the Health Forum is a current grantee of the Centers for Disease Control and Prevention and the California Endowment. Funding for this webinar has been through the generous grant that we received from the California Endowment. Today we're conducting a webinar on Asian American, Native Hawaiian, and Pacific Islander cancer data, and specifically also having some discussion around a statewide California data disaggregation bill. I'm going to hand this over to Trish, who will now talk about instructions and logistics for the webinar, and then we'll introduce our guest speakers. Trish?
Thanks, Rox. Hello, everyone. Let me just share a few webinar tips with you guys. So on your screen, you should be able to see the control panel, which appears on the right side of your desktop. After approximately 10 seconds, the control panel automatically collapses to the right side of your screen with only the Grab tab displayed. So the Grab tab is the small column of buttons where you can see an orange arrow at the very top. So the orange arrow allows you to open and close your control panel. Finally, for those who want to ask questions during the webinar, you will use the questions pane, which is located on the lower half of your control panel. So you should see a tab that says questions and then enter a question for staff. So just type it in and then you can send your questions over to us. We will be collecting your questions throughout the presentation. And we will have time at the end of both of our presentations to answer your questions. And also for those who are asking, we will be recording this webinar and we will make it available online, and we will share information to you guys at the end of the webinar. So with that said, let me hand it over back to Rox, who will be introducing our speakers.
So we're now proud to introduce two of our webinar presenters today, Mr. Zul Surani and Assemblymember Mike Eng. Our first presenter is Zul Surani, who will be presenting on the cancer and data portion of the webinar. He is the SAS USA co-founder, the Cancer Survivors Network National Advisory Council Chair, and the NCI National Outreach Network Liaison to WINCART, which is the Weaving and Islander Network for Cancer Awareness, Research, and Training. Our second speaker is Assemblymember Mike Eng, who represents the 49th Assembly District in the San Gabriel Valley of Southern California. He is the chair of the Assembly Banking and Finance Committee and formerly chaired the Assembly Select Committee on Hate Crimes. Assemblymember Eng has disseminated legislative reports on AA, Asian American and Native Hawaiian Pacific Islander disparities in health, mental health, and education. We're so fortunate to have both of our speakers join us this afternoon. We know they're very busy, and we'll definitely have some time afterwards for any questions and answers. So with that said, we would like to begin the presentation with Zul. So Zul, you can begin at any time.
Thank you, Roxana. Hi, I'm Zul Surani, and I'm really honored to be here today and to present for the API Cancer Survivors Network and on the same call as Assemblymember Mike Eng. I just also wanted to bring up that I think Roxana forgot to mention that I work at the University of Southern California at the Norris Comprehensive Cancer Center, and I manage USC Norris's Community Outreach and Partnerships Program for Los Angeles. But I'm also the chair of the Asian Pacific Islander Cancer Survivors Network, and the Cancer Survivors Network is a national network, and it was co-founded in 1998 by Susan Shinagawa and the late Reverend Frank Chong. And many of you probably know Susan, who's a national mover and shaker in our community and has created an incredible impact and has started this movement that has resulted in so much for Asian and Pacific Islander cancer survivors throughout the country. It is a part of the Asian Pacific Islander and American Health Forum, which was founded in 1986, APIHF. The mission is to advocate for greater recognition, inclusion, and engagement of Asians and Native Hawaiian and Pacific Islanders on policies and programs that are critical to the health and well-being of our diverse communities. The next slide is a slide of a map of Asia. And as you can see, Asia is really vast, and many of the U.S. Asian populations trace their origins either directly for some of these countries or via other countries. They're diasporic, like myself. I actually was born in Kenya, but I trace my origins to South Asia, to Gujarat, and eastern part of India. The next slide talks about the different groupings of Asians. So for example, Asians are either from the Far East, Southeast Asia, or the Indian subcontinent. And as you can see, they're broken down further. Some of the examples you can see, for example, Far East are comprised of Japanese, Korean, Chinese, and Southeast Asia are comprised of, for example, Hmong or Filipino or Thai, and in terms of the Indian subcontinent, Asian Indian, Bangladeshi, Nepali, Pakistani, and Sri Lankan. The next slide is the map of the Pacific. And you know, when we think of the Pacific in the U.S., we think of the U.S. Pacific territories. But if you look at the map, it's a really vast area, and there's many clusters of islands throughout the Pacific, all of whom are considered Pacific Islander. And this is important because this area shares a similar political history, for example. They were initially colonized by the Spanish, then the Japanese, and the U.S. And all of this has an impact on the way people from the Pacific live, the way they identify. The next slide talks about the different groupings of Pacific Islanders and Native Hawaiians. And if you look at the groups, they include Polynesian, Micronesian, and Melanesian. And in the U.S., those Pacific Islanders that reside in the U.S. most likely come from, for example, are most likely Samoan, Tongan, Native Hawaiian, Chamorro, Marshallese, Fijian. And if you look at the next slide, sorry, I'm going a little fast here. The U.S. Asian population is the fastest growing U.S. population. And if you look at the 2010 data, which I'm still getting used to, it's fantastic to have 2010 census data that is broken up this way. There's been a 46% increase in the Asian American population. So again, it's the fastest growing U.S. population. And similarly with Native Hawaiian and Pacific Islander, there's been a 40% growth in this population. The Asian American and Native Hawaiian Pacific Islander population in the U.S. are a very diverse population. And this kind of diversity has an incredible impact in terms of access to care, policy, people's lived experiences, how they self-define, how they choose to categorize themselves, how others categorize them. So for example, there's 30 distinct Asian ethnic and cultural groups, and 60% of Asians in the U.S. are foreign born. And while this is 2009 data, 50 distinct Native Hawaiian Pacific Islander ethnic and cultural groups, 12% are foreign born. There's an incredible number of languages and dialects that are spoken between these two communities. As you can see, I'm seeing 2,000, and then I'm also seeing 100. So there's different sources of different information, but as you can see that, the diversity is incredible. And that has a tremendous impact in how these communities are served. So if you look at the 2010 census data, it's much, much, much more inclusive. And you see a breakdown of all the different groups. And a lot of advocacy went into ensuring that communities are represented and included and broken down this way. And so if you look at the population, you'll see that, for example, the Chinese, in terms of Asians, the Chinese are considered the largest group, followed by the Filipino community and Asian Indians. And if you look amongst the Pacific Islander, it's Native Hawaiian, followed by Samoan and Chamorro. Okay, and this is Census 2010 data. Now, this is a cancer incidence slide, cancer incidence rate slide by race and ethnicity. And this is data from the U.S. Cancer Statistics Working Group. And this is what we typically see in a lot of reports. If you can, to interpret this slide, the overall cancer incidence rates are higher in men than women. African American men have the highest cancer incidence, followed by white, Hispanic, Asian Pacific Islander grouped together, and American Indian and Alaska Native. Okay, and then if you look at the death rates, again, the overall cancer death rates are higher in men than women. And again, you see that with the Asian and Pacific Islander community, it shows that the community has the lowest cancer death rates, about half the rate of African American men and women respectively. And this sends a message that there really isn't a problem in the community, that while there are death rates, they're not as high as the other communities. So I guess the big question is that in terms of cancer health, do inequities really exist? So let's look at the next slide that focuses on colorectal cancer incidence and mortality. So if you look at the colorectal cancer incidence and mortality, incidence rates amongst Asian Americans and Pacific Islanders, Hispanic, Latinos, and American Indians are lower than those amongst the whites. And then mortality rates are also lower, suggesting that the differences in risk factors rather than access may play an important role. But again, it clearly shows that that there isn't a problem. When you look at this, you kind of say that there isn't a problem. So what is the real story? And the real story lies in, excuse me, in disaggregating the data. So I'm going to give you a couple of minutes to look at this slide, because there's a lot of colors, and just, it takes a minute to digest it. So if you look at the slide, the bright pink is the aggregated data. And if you look at women and men in terms of colorectal cancer incidence, you see that in the aggregate it's 38.6, and for men it's 56.3. And when you look at it broken down, it really tells you a different story. That the rates, you begin to look at the rates amongst the subgroups, and they're pretty alarming. So, for example, in terms of colorectal incidence, for Samoans, it is 36.8, and we never would have known this had it not been broken down this way. And if you compare that to the other groups, it tells a different story. So, for example, for Chinese men, it's 40.2, and that creeps up with close to the other groups as well. And for men, again, it's a similar story that when it's broken down, you see, for example, Native Hawaiians at 65.7, and we never would have actually known that had we just looked at the 56.3 number. So, so I guess when data is disaggregated, the real story is exposed in terms of cancer amongst Asian and Pacific Islander communities. The same thing with cancer mortality as well. And if you break it down, you see, for example, that the Samoan population, Samoan men have the highest death rates from colorectal cancer than any other group. And I guess for women, again, for women, Chinese women are also standing out as having very high death rates from colorectal cancer. And the same with Japanese men as well, at 25.8%. Next slide. So studies have finally begun to break down the cancer burden in the Asian and Pacific Islander communities. And we are beginning to see that the cancer burden is unique, it's unusual, and it's also unnecessary, and in many cases entirely preventable. So we're going to look at why it's unique. And the cancers that occur amongst Asian and Pacific Islander communities are cancers that are lower incidence in the general U.S. population. And so many common cancers such as stomach cancer, liver, and thyroid don't occur as frequently in the mainstream American white population than it would in Asian and Pacific Islander populations. And then Asian and Pacific Islander women, for example, were the only U.S. population group that experienced no decrease in cancer incidence and an overall increase in cancer mortality for all cancers combined between 1990 and 97. And this was reported in the 2009 annual report to the nation on cancer. And we're seeing that these trends are continuing. So cancer has been the #1 killer of Asian American and Native Hawaiian Pacific Islander women, at least since 1986, and of men since 2004. The cancer burden is also unusual. For immigrant populations, for example, acculturation and time since immigration in the U.S. can either affect them positively, so some cancers that occur in the homeland don't occur here, but they can also affect them negatively. So with acculturation, for example, breast cancer rates have risen in the Asian and Pacific Islander populations. So, and there's cancers that are caused through infectious diseases like the hepatitis B and C virus that leads to liver cancer, or HPV that leads to cervical cancer. And cervical cancer is entirely preventable, but we're still seeing rates of cervical cancer, for example, occur in Pacific Islander communities as well. So the cancer burden is unnecessary as well, and some of this is probably because of access issues, but also things like vaccinations from hepatitis B and learning to screen early for cervical cancer as well. And if these issues are controlled, then amongst Asian and Pacific Islanders, we would probably see a lower liver cancer and cervical cancer rate. Other issues are lack of awareness and understanding and trust of the U.S. healthcare system. Many don't have regular providers or adequate health insurance. Again, language access is huge, and there's other barriers. There's cultural barriers. So all of these have impacted, for example, Asian and Pacific Islander women in terms of having some of the lowest cancer screening rates. And in California, the California Health Interview Survey has documented this very well on several occasions. The tobacco industry as well. When we look at risk factors for cancer, tobacco use is extremely high amongst Asian and Pacific Islander communities, and the tobacco industry floods Asian and Pacific Islander nations with tobacco products and target markets in minority communities, especially to children and teens, which have led to rising smoking rates in these populations. And, you know, there's also this issue of, you know, transnational issues where communities go back and forth and bring and use products that are commonly used in the homeland as well. So, for example, with South Asians and smokeless tobacco, that's a big issue in India, and we're also seeing an emerging trend in this country as well. When we look at the most commonly diagnosed cancers, and you know what, I'm going to let you take a couple of minutes to digest this. So again, when we look at the cancer profile in Asian men, for example, it's great that it's now broken down and we can see the differences in terms of the top cancers. But if you look at the profile, you're also seeing cancers that are not common in other groups like we talked about before, like stomach cancer or liver cancer or non-Hodgkin's lymphoma. And, you know, all of these really have an impact in terms of cancer control priorities for the communities and what should health departments focus on as well. It's the same for women as well. We're seeing, for example, amongst Asian women, there's cancers such as endometrium cancer that you don't see in other populations at such higher rates. And, you know, even though you see the top cancers like breast, lung, colorectal, but you're also seeing endometrium, cervical cancer, stomach, and liver cancer affecting certain Asian groups, subgroups. In terms of Pacific Islander men, again, we are seeing a unique profile of cancer, bladder cancer, for example, non-Hodgkin's lymphoma, stomach, and liver cancer as well. And we really have no data on melanoma. In terms of women, again, like I said earlier, we have cancers that are, for example, endometrium cancer is extremely high amongst, for example, Chamorros and Native Hawaiian women. And so what does this mean in terms of cancer information for the community? And how is this addressed in terms of, for example, clinical trials and starting new trials for these populations and making sure that these populations are represented in clinical trials? Native Hawaiians have a 124.8 per thousand rate of breast cancer, extremely high, second to non-Hispanic whites. And, you know, usually people say that Pacific Islanders don't have high breast cancer rates. And so, you know, this type of disaggregation really brings the needs of the community, makes us aware of the needs of the community. So, you know, another issue that I wanted to just quickly bring up is that personalized medicine shows promise in terms of cancer treatment. However, personalized medicine means that specific populations have to be targeted for biospecimen collection and banking, and these are emerging issues in cancer treatment. And when you look at these, when you look at the data broken down like this, this tells you that, you know, yes, we do need to target, for example, Native Hawaiian women. Yes, we do need to target Samoan women for personalized medicine clinical trials, and that cancer centers throughout the country need to be thinking about these issues and these populations. Since 1996, breast cancer incidence rates have declined for all U.S. women except for Asian Pacific Islander women. And deaths from breast cancer also continue to rise. And, you know, I had seen registry data on South Asian women showing that South Asian women have some of the lowest breast cancer incidence rates. And, you know, I'm not sure, again, the need to break down this data is also critical. And I actually on several occasions have challenged the registries that they need to further break it down so that we see a clearer picture. So when we disaggregate the data, it tells us a different story. So given the facts that you have seen, why do breast cancer statistics most often show API women as having some of the lowest breast cancer incidence rates and mortality rates in the U.S.? And so I guess this explains why providers tell their Asian and Pacific Islander patients that they don't need to worry about breast cancer because they're not at risk, because the data is presented in a certain way to them as well. So the key to understanding critical health issues for Asian Americans and Pacific Islanders is knowledge of U.S. Census demographics, immigration, and the impact of data aggregation on the collection and reporting of health surveillance data. And I guess that collecting and reporting disaggregating data points out the groups with the highest and the lowest rates, really the real groups, the real picture. And this helps us make cancer control research, clinical trials, funding decisions. It really helps us make better decisions in terms of funding decisions that pertain to these populations based on aggregate rates that only serve to create disparities. Okay. I actually am going to skip a few slides just because I'm running out of time, but I wanted to just touch upon the fact that again, we talked about the profile of cancer being different, and many of them as a result of infectious diseases being introduced to the Pacific Islands. And you look at, we talked about hepatitis B, stomach cancer, leading to liver cancer, stomach cancer, cervical cancer from sexually transmitted diseases, obesity as a result of westernization that has affected the island people's health. The next slide, for example, we're talking about the barriers that affect immigrant populations in this country. For example, social isolation, language barriers, and socioeconomic status as well, high poverty rates, uninsurance, lack of insurance. People are, even though they're working 2 full-time jobs, they still don't have health insurance coverage. Now the next slide looks at the 8 of 20 languages most frequently spoken at home are Asian languages, and I was kind of happy to see Gujarati being one of them. That's a language that I speak. And the next slide shows data on, broken down data on limited English proficiency. And it's pretty interesting to see the different rates when it's broken down this way. Okay? And, you know, limited English proficiency obviously affects everything. It affects how you access healthcare, health information, your ability to get a job, make money, support your family, support your family's health, eat certain type of foods, it really affects a lot of things when you look at it differently. Okay? The same with Pacific Islanders. Again, very high rates of limited English proficiency as well. And if you look at 2009 numbers, that'll give you a clearer picture. So for example, Samoans have 16% of Samoans are limited English proficient. And a lot of people don't think of, for example, Pacific Islanders as being limited English proficient. So language barriers, again, really impact health of the community because people are unable to interact with healthcare providers, social service agencies. They're most likely timid to ask for an interpreter. They rely on family and friends as interpreters. They tend to be non-compliant with their medication, and all of this has an impact on healthcare outcomes in the end. Okay. In addition to that, a lot of members in the community are uninsured, and uninsurance rates have increased as a result of the economy as well that may not even be captured in this data. Okay. Social class and SES also has an impact on cancer survival and mortality, and there's a lot of research that's showing that. Low SES patients have poor survival in comparison to their counterparts, and mortality is very high in these populations as well. Now, this is a great picture. It was taken at the Pacific Islander Festival in San Diego by Susan Shinagawa. And again, you know, this a lot of healthcare workers, healthcare providers misclassify, for example, in this case, Pacific Islander communities, because, you know, for example, I'm often misclassified as Hispanic, Latino, or Middle Eastern, and most people don't think I'm South Asian. So, you know, that has become a huge issue in terms of how data is collected, how it's reported, how it's used to plan public health programs. So this root cause of misclassification has a huge impact at the other end of it. Why does any of this matter? Well, the U.S. Cancer incidence amongst Asian and Pacific Islander is expected to rise. And, you know, I kind of questioned how the researchers were able to do this, but there's many different factors that play into how they're able to project this kind of data in terms of population growth, in terms of risk factors, diet, exercise, tobacco use, screening rates. All of these can be plugged into formulas that can project the incredibly high, the rate of cancer rates in, for example, 2030 are projected to be very high, as you can see in the table. And again, for the top U.S. cancer sites by race and origin, the projections, again, are incredibly high for Asian and Pacific Islander communities for cancers that, you know, for example, bladder cancer or pancreatic cancer, esophageal cancer. And are we doing, for example, pancreatic cancer cannot be detected early, and enrollment in clinical trials are very promising for people who have pancreatic cancer. So is that happening within Pacific Islander communities? So to summarize key points of this presentation, and a lot of the issues we talked about today impact the health and the willingness of people to get timely health care. So to summarize key points, to understand critical health issues for API communities, we need knowledge and understanding of census, demographics, immigration, refugee status, so many different sociocultural variables. And we need also each of these population groups, geopolitical history has had major implications on the health inequities, health status, and health outcomes of people. And then cancer and other health data collected reports API in the aggregate, which is virtually, as you can see, meaningless. Aggregate data obscures cancer reality and does not help us plan cancer control priorities within each of the different populations effectively, and ultimately has an impact on health policy decision making, which is done only on the aggregate rates rather than breaking down the data, which would have a bigger impact on, for example, cancer health inequities for many of the Asian American and Pacific Islander communities. So what can be done? We must begin and end with the communities. That really the communities need to be part of everything, and that we need to address language access, that providers need to be culturally competent. There's just so much literature that is now emerging on this area, and that it can only be done through partnerships and collaborations, that many of the Asian and Pacific Islander community agencies have so much history, knowledge, and understanding of their communities. And so, you know, it's imperative that they be engaged in this process as well, and that community-based participatory research be a component. And, you know, I'm working with a phenomenal program, Weaving an Islander Network for Cancer Awareness Research and Training, funded by the National Cancer Institute to Cal State Fullerton. And, you know, that is a true model of community-based participatory research, and as a result, there's been so many advances in terms of bringing in knowledge around cancer for Pacific Islander communities, and then ultimately be responsive and accountable to all Asian American and Pacific Islander communities that we serve. So I want to end by putting in a plug for the Asian and Pacific Islander Cancer Survivors National Network, and we would like for everyone to join. And as you can see, you can join through Facebook and by also emailing Trish. Also, you can, you know, call up the health forum that houses the network, and then I'll hand it over to Assemblymember Mike Eng to continue on the discussion.
Thank you very much
for sharing all the wonderful information. We did learn a lot. At this point, we would like to begin with the second portion of our webinar. And with that said, Mr. Eng, you can begin anytime.
Yes, well, hello everybody, and thank you so much. This is California Assemblyman Mike Eng, and just for identification purposes, I represent the 49th Assembly District, which is in the San Gabriel Valley in beautiful Southern California. It's really an honor to be with you today, and I wanted to, first of all, thank the Asian Pacific Islander American Health Forum and all of the participants for hosting what I think is one of the most important discussions of our time, and that's on cancer data and policy issues for Asian Americans and Native Hawaiians and other Pacific Islanders. I feel personally very moved by the discussion that has taken place, not just today, but in the past few years. Just by way of personal history, I was raised in the state of Hawaii, and the communities that I grew up in and went to school and worked in very, very much reflected the diversity and the richness of the Asian American, Native Hawaiian, and other Pacific Islanders. And so for me, each community was distinct in terms of its culture, in many cases language and needs. And then coming to California and finding out where a lot of the information that we get is aggregated into a euphemism called Asian. And by way of personal introduction, I want to say that I just lost my sister, who passed away, I think at a prematurely early age, largely due in part because she did not have the type of information and the type of advocacy and the resources that are becoming clear as a matter of life and death and survival in our community today. So I want to thank all of you for taking up a policy issue that is very important to me. And so why am I here today? I'm here today not because the biggest injustice is having a stereotype that Asian women perhaps don't have breast cancer, but from where I sit, the biggest injustice is the fact that policymakers, funders, and many others in our political community don't have any idea that we even exist other than in a large category. So in conclusion, I will be tempering my comments more from the point of view of a legislator as opposed to someone that has specific hard data to announce to you today. Thank you. Let's go to the next slide. The reality is that in order to close the gaps in health incomes, we must identify where the gap exists. It's imperative to collect accurate, standardized, and comprehensive demographic data on racial and ethnic minorities and underserved populations. The reason is very clear. The reason is that because if we don't know who we represent at the legislative level, then we don't know how to represent them and us. And it's important because as a legislator, in order to make decisions that affect the allocation of critical resources, if we don't know which communities have specific needs, then it is very easy to see why many of those communities that we're talking about today end up not getting resources that are very important for their viability. Next slide. One policy solution that I have pursued for the past several years along with other legislators in the state legislature has been to focus on our state agencies that are collecting demographic data for us to make decisions on. For example, on any given day, as a legislator, I, like many others in my peer group, make decisions on education, on corrections, on transportation, on the safety net. And we often look to data collected by our state agencies to tell us where the needs are. However, when we look at those agencies, many times the information is homogenized into a category called Asian, or in some cases they're homogenized into a category called Other. For example, recently I had to vote on some legislation involving the treatment of juveniles that were tried as adults. And I asked a question. I said, where does the Asian American, Native Hawaiian, and Pacific Islander community fit in the continuum of law enforcement and corrections? And I was given a spreadsheet which showed the terminology and the data for Anglos, for Latinos, African Americans, and then there was a category of Other. Now, according to the 2010 census, Asian Americans, Native Hawaiians, and Pacific Islanders make up 15.5% of California's population and represent the fastest growing racial and ethnic group in the state, increasing nearly 34% in the last decade. But if you were to look on websites or reports in which data collected by ethnic group, by California and most other state agencies, you would not be able to conclude that this is an important ethnic or cultural group that deserves to have disaggregated data. And so as a result, these communities are not represented as a homogeneous group, but rather, no, a correction, these communities are not represented as specific different groups with their own poverty rates, health status, income, educational attainment, and immigration patterns, but instead they're lumped together into one homogeneous group. And so that's why the myth of the model minority becomes something that ends up being a policy, not just a stereotype. Because of this diversity, the U.S. Office of Management and Budget issued Policy Directive 15, which recognized Asians and Native Hawaiians, Pacific Islanders as two separate categories. Next slide. In order to identify and address the unique needs of these diverse communities, it's important to disaggregate data for these groups. And that's why I introduced Assembly Bill 1088, sponsored by the Asian Americans for Civil Rights and Equality, ACRE, the Asian Pacific American Legal Center, APALC, and Asian and Pacific Islanders California Action Network, APIs, CAN, requiring specified departments to collect demographic data to include the full spectrum of the Asian American, Native Hawaiian, and other Pacific Islander ethnicities. It would add Bangladeshi, Hmong, Indonesian, Malaysian, Pakistani, Sri Lankan, Taiwanese, Thai, Fijian, and Tongan to the existing group of 10 disaggregated Asian American, Native Hawaiians, Pacific Islanders. Our bill will ensure that data collected by these departments are collected and disaggregated into the top Asian American, Native Hawaiian, and other Pacific Islander ethnic groups to align us with the federal U.S. Census category. Current state agencies that gather demographic data must disaggregate the data into a limited number of these categories, specifically Chinese, Japanese, Filipino, Korean, Vietnamese, Asian, Indian, Hawaiian, Guamanian, Samoan, Laotian, and Cambodian. Current law does not include many other of the, some say 30, and I've seen a report up to 48 different Asian American, Native Hawaiian, and other Pacific Islander groups. And that's where we need to work even harder to include more departments and more ethnic categories in future legislation. Next slide, please. Now, the disaggregation of demographic data for these diverse Asian American and Native Hawaiian and other Pacific Islander ethnicities enables state agencies and social service providers to analyze who is and who is not benefiting from the vast array of services provided by the state. Let me give you an example of how important disaggregation is. If you were to look at breast cancer rates for men and women in which the data was lumped together, you would conclude that there really isn't a health risk or problem. It's only when you disaggregate the data for men and women do you realize that there is an issue. And so that's why our bill, Assembly Bill 1088, also adds transparency and accountability by requiring these agencies to make this information available to the public by posting it on the agency's website. And in so doing, we have the disaggregated data available not just to legislators and our staff, but available to the public as well. Utilizing disaggregated data to develop targeted programs for the underserved reduces future costs to the state by providing proactive and preventive assistance to these groups prior to the problems that arise when you don't have prevention. Next slide, please. Now, earlier versions of the bill focused on requiring that the State Department of Health Care Services and the State Department of Public Health, among others, be required to collect and tabulate data for the additional major groups, or a total of 21 groups, and make that information publicly available online. Focusing on health care was extremely important because as we've heard from the previous presentation, that health data is really a matter of life and death for our communities. In the area of mental health, for example, we found that Vietnamese, Native Hawaiians, and Pacific Islanders experience mental distress at higher rates than other groups. And yet the Vietnamese population in California are the highest insured Californians who are without mental health coverage. Additionally, as we've seen, our community is affected by colorectal cancer, relatively low in comparison to other groups, but looking at a comparison within our community, it becomes clear that certain groups have the highest rate of this type of cancer. Unfortunately, when the bill made it to the Senate Committee on Appropriations, we were forced to remove these two departments from complying with the provision of the bill because they would have incurred additional costs. And it's really ironic because when you disaggregate data, we know that you can have a program of targeted prevention and as such save costs later on. So unfortunately, with the reality of our economy and the budget process, we had to agree to remove those two health departments from complying with provisions of the bill. Additionally, the bill had some opposition from some of the departments that are important in the decision-making process. And why do I mention that? I mention that because just to get to this point in California's history required an incredible lobbying effort, and we want to thank the dozens of people that came up here to speak to the bill. But so much more is important that we need to do. Next slide. The fiscal environment that we must operate in made it impossible to keep previous versions of the bill. We had to narrow down the bill to require the Department of Fair Employment and Housing and the Department of Industrial Relations to collect and report the data because they would only incur minor costs. And as such, those were the two departments that remained in the bill. Adding the 10 additional groups included in the demographic data, however, is still an important first step in making sure that in California and in Sacramento that we realize the necessity of at least a minimum of 21 specific different Asian American, Native Hawaiian, and other Pacific Islander groups. So this advance, although a relatively small step, is a very important one. And if we look at those two departments, they will address issues of employment, housing, and worker conditions which cannot be normally addressed had the bill not gone through. The strategy in moving forward with the bill eventually is that all state agencies collect and disaggregate data for the very many groups that exist in California. After all, Asian American, Native Hawaiians, and Pacific Islanders have been communities that have long paid our taxes. We've played by the rules, and we deserve to have resources at the state level made available to our communities. Next slide. A recent article in California Watch spoke about the importance of the bill, specifically to the Tongan community, which would be one of the 10 additional groups that are included in the data collected by two state agencies. It is highlighted that of the more than 57,000 Tongans in the United States, 50% or nearly 23,000 live in California. But you won't find them identified in California data because the state does not require agencies to count them until now. And the article concluded with a quote that summarized the need for the bill. The article quoted Alisi Talua of the Tongan Community Service Center, a nonprofit group serving Tongan communities in Southern California, who said that, quote, if we can show that having that data is useful in these departments, then we can advocate in the future for other departments to include us. It's a great stepping stone for us, a great place to start, and it surely is better than nothing, unquote. Next slide. I started my discussion by stating that in order to close gaps in health incomes, we must first identify where that gap exists. I conclude by saying that we must continue to pursue policies that disaggregate demographic data. We need to put pressure on local and state and federal officials to hold them accountable for the various communities that they serve and that have needs in the state of California. And this is working. For example, in California, we have collaborated between the Asian Pacific Islander Joint Legislative Caucus, which is the Asian Americans elected at the state level, and the University of California Asian American and Pacific Islander Policy Multi-Campus Research Program, the MRP, that led to the development and publication of reports pertaining to the health and education status of our communities in California. These reports mark the beginning of the development of a body of information whose time has come. And we've collaborated on reports that have disaggregated data for policymakers on education, health, mental health, and fairly soon to come, the issue of Asian Americans and the justice system. And so when Assembly Bill 1088 was signed by Governor Jerry Brown, it was the epitome, it was the result of hard work from individuals and organizations, public institutions, congressional leaders from throughout the state of California and the nation, all moving together in harmony with a very common message. And that message is this: our time has come. Even as our ancestors have come from the shores of their home country to the shores of America, it is now our time. It is our time to stand up and be recognized. We know that we represent many different communities, and we're often seen as perhaps one or two. I myself have experienced the same recognition disconnect as was noted by the last speaker. In fact, sometimes, even in the state legislature, I have been mistaken for other Asian American legislators. But make no mistake, we must fully recognize the uniqueness and the important needs of our Asian American Pacific Islanders and Native Hawaiian communities. We must bring to the forefront information that says that our Vietnamese, Laotian, Cambodian Americans in California have communities that suffer from post-traumatic stress that is clinically measurable, just as it is for those that have returned from the war in the Middle East just a few days or weeks ago, even though our communities returned from those wars many decades ago. It is important for us to realize that Korean Americans have some of the lowest insurance coverages in the state of California, that some Asian American, Native Hawaiians, and Pacific Islanders have a higher rate of probation offending than other groups in California, or similar to those that have had issues with the criminal justice system. So therefore, in conclusion, I thank you for joining us on this webinar, and I look forward to moving from research and data to action, political action, because your time and our time has come. Thank you very much.
Thank you, Assemblymember Eng, for that very engaging and moving. I mean, especially during the introduction, the moving story that you had shared with us. Before we go, we don't have time to answer everyone's questions, but we did. There was one question. I think we have time for one question in the This question is for Mr. Eng. When do we expect to see results from the data disaggregation in the Departments of Fair Employment and Housing and Department of Industrial Relations?
The bill required that effective in July 1st, which is only a few months from now, that those agencies will be posting the information on their website. And they can feel free to contact my office. You can Google, Assemblyman Mike Eng, ENJ, and we'll be happy to give you that information if you're looking for it. And hopefully we can work together to make sure that there are more departments and more of the ethnic groups that represent our community will be included in future legislation.
Thank you, Mr. Eng. We just pulled up our slide again. If you do have additional questions, feel free to email me. My email address is there on your screens. And also, you will, just a few announcements, you will be receiving a short survey from us before this webinar ends. As this webinar ends, it will only take a couple minutes. So we do appreciate your responses. It will help us in improving our work and providing more webinars in the future. And your feedback, of course, will be most appreciated. And also for those who want to review the webinar again, we will be providing a recording of this webinar, which is available on our YouTube channel, youtube.com/APIAHS. And finally, we are promoting our Cancer Survivors Network Facebook page, so please go on Facebook and type facebook.com/APINCSN, and please like our page. And with that said, let me thank everyone for joining us. Thanks to Zul, Surani, and thanks to Assemblymember Mike Eng. And thank you everyone for joining us today. We hope that you can participate in future webinars hosted by the Health Forum and the Cancer Survivors Network. So with that said, thank you for sharing your time with us, everyone, and we will be concluding this webinar. Thanks, everyone.